Hello. Well, welcome everyone to session number 3. We are going to have a talk from Dr. Allison Chan and Patricia Dang from Hamilton Health Sciences Center on a transcutaneous neuroprosthetic system in transtibial amputees. So I'll hand it over to Allison and Patricia. And questions in the Q&A and chat, and I'll moderate them at the end.
All right, thank you, Dr. Mayo, for that introduction. I'm just going to share my screen. Can I get some confirmation that you can see these slides and hear my voice?
You're good, Allison.
Okay, perfect. Thank you so much. All right. So welcome everyone to our breakout session. As Dr. Mayo mentioned, my name is Allison Chan. I'm a resident at the McMaster Physiatry program. We're very excited that OAAC has invited us to speak at this talk and that you've joined us today to learn about some of the research that we're doing here in Hamilton. So we'll be presenting our project today on phantom stimulator in transtibial amputees, a transcutaneous neuroprosthetic system. And I'm presenting today with my colleague, Patricia Dang, who's a prosthetist at Hamilton Health Sciences. So the objectives for today's talk, we're going to be going over an overview of neuroprosthetic systems. Then we'll introduce our intervention, the phantom stimulator. We'll talk a little bit about referred sensations, what they are, how to map them, and present some case studies on referred sensation areas. And finally, we'll give an overview of the project design. So to start with an overview of neuroprosthetic systems. A neuroprosthetic system is a closed loop system where a patient has motor control of their prosthesis and then also receives sensory feedback from their prosthesis through some sort of neurostimulation, usually an electrical stimulus. The goals of neuroprosthetic system are to improve function, so to improve motor control, improve the embodiment of the prosthesis, and ability to navigate the environment. And what's been shown through the research is while it has been improving function for amputees, we're also seeing that it reduces phantom limb pain. One of the theories behind it is something called the cortical reorganization theory that I'm going to explain in a little bit more detail here. The cortical reorganization theory is a theory that there's an expansion and invasion within the somatosensory cortex after amputation. So if we look at this diagram here, this is a little cartoon drawing of a patient before amputation. And you can see on the primary motor cortex and sensory cortex of the brain that there's this representation on the homunculus of different body parts. So after amputation of the hand and the fingers, you lose that input into the homunculus area of the primary motor and sensory cortex areas. And this gives the opportunity for other parts of your body to go into that area of your brain. What can happen then is if you touch certain areas, such as the face, the amputee may feel like you're touching their phantom hand or phantom fingers. And these areas on the face where you feel that are referred to as referred sensation areas. Patients with phantom limb pain have been shown to be patients with phantom limb pain who have cortical reorganization are more likely to have phantom limb pain than patients without. And so the thought is that you can target these cortical map changes in therapy. If you provide somatosensory feedback to these areas, you can reestablish these pathways, reverse cortical reorganization, and reduce phantom limb pain. This is a little cartoon schematic of the peripheral nervous system, starting from the alpha motor neuron in your spinal cord, coming down to your nerve, going to your muscle, and then coming back to the spinal cord. So neuroprosthetic systems will need to interact with this peripheral nervous system, and this gives us two main places where you can interface with the peripheral nervous system, and that's the nerve and that's the muscle. Currently, there are many different methods to interface with the peripheral nervous system. One is interfacing with the muscle, as we were previously discussing, so picking up signals that come from the muscle. You can do this using electrodes, surface electrodes over the muscle, implanted electrodes over top of the muscle or within the muscle, called intramuscular electrodes. Or this can be done with more advanced surgical techniques such as targeted muscle reinnervation or regenerative peripheral nerve interfaces. You can also interface with a nerve and pick up signals directly from the nerve, and this is done by implanted electrodes either through a cuff around your nerve or an implanted electrode that goes within the nerve, or this little device here where the transected nerve can grow into an amplifying device to amplify the nerve signal. Another way to interface with the peripheral nervous system is transcutaneously through referred sensation areas. And to call back to this cortical reorganization theory slide, the referred sensation areas are those places where when you touch another part of the body, the patient with amputation may feel like you're touching their phantom limb. To interface with these referred sensation areas, electrodes are placed transcutaneously over those places where we find these sensations. And while this doesn't allow us to pick up as much of a signal as it would if you were recording over a muscle or over a nerve, it allows us to deliver a stimulus directly to these areas. And so the primary goal here is to provide sensation that represents the phantom limb. So we're not so much picking up the signal from these referred sensation areas, but more so delivering stimulus to these areas instead. So now we're going to talk about our phantom stimulator. The phantom stimulator is a transcutaneous neuroprosthetic system. It was developed in Germany and currently commercially available in Europe, and it improves mobility and phantom limb pain. These are the components of the phantom stimulator. The individual will use their own prosthesis. There's a sensor sole that's placed under the prosthetic foot. These electrodes are placed on the individual's skin, and the phantom stimulator unit can hang on the endoshank here. This phantom stimulator unit will interpret signals from the sensor sole, and it'll also deliver stimulus to the electrodes. The sensor sole has sensors on the forefoot of the prosthetic foot and the heel of the prosthetic foot, so that when the individual is walking, it can detect where the individual is in the gait cycle. This pattern is registered by the phantom stimulator. The phantom stimulator then generates an electrocutaneous stimulus pattern, and this stimulus pattern is sent to the transcutaneous electrodes. These electrodes are strategically placed on referred sensation areas through a mapping procedure that my colleague, Patricia Dang, is going to explain now. Patricia.
For my section, I'm going to be talking about the mapping process for referred sensation areas and our proposed project design. Allison mentioned earlier the term referred sensation areas, or RSAs for short, and I just want to highlight this term again as it plays a big role in our project. RSAs are regions on the body that evoke sensations of the phantom limb when stimulated as a result of cortical reorganization. So why do we care about these referred sensation areas so much? The idea behind the phantom stimulator is to exploit these RSAs and use them as artificial sensory feedback for the phantom limb. For this neuroprosthetic system, we will specifically look for referred sensation areas of the plantar aspect of the heel and plantar aspect of the phantom forefoot. Transcutaneous electrodes will be applied over these referred sensation areas to provide a stimuli whenever the associated force sensors underneath the prosthetic heel and prosthetic forefoot are triggered. In order to find these referred sensation areas, we adapted a mapping process through a series of previous referred sensation area studies, as well as previous complex regional pain syndrome allodynia studies. So the first step for the mapping process is to ensure that we have an optimal environment. Creating a calm environment for the individual and creating the most relaxed state as possible is very important for this process. We'll start our mapping process at the most distal aspect of the residual limb, and we'll move proximally up towards the thigh following the nerve pathways. If we are unable to find any referred sensation areas on the lower extremity, we'll then move to the proximal areas of the homunculus of the ipsilateral shoulder, arm, and forearm. And we'll be working in a systematic approach to ensure that we have covered all aspects of the limb. We'll be working in 2 centimeter areas and ensuring that we have breaks in between moving from one area to the next so that we know that there's no crossover in terms of sensation when moving to a new testing area. This testing process, we hope to use a variety of brushes and size of paint brushes. And these brushes will be used to just paint, brush lightly over their skin in order to help elicit sensations. I think it's really important throughout the whole process to just be cognizant of the individual's changes in behavior or reactions, as that may indicate that there's been a elicitation of phantom sensation. So if phantom sensation is elicited, we will hone in on that area and try to define the borders of that referred sensation area. Once these borders are found, we'll mark and photograph and record these areas for our future references. So when we first heard about the idea of referred sensation areas and the idea of eliciting phantom sensation through this brushing technique, we were a little skeptical at first. So as a group, we decided to conduct a small case study of 3 transtibial amputees to see if we can elicit any of the referred sensation areas or phantom sensation. So in our first case study, we have patient H, a 49-year-old female. She received her amputation in 2017 due to a motor vehicle collision. She states that she experiences phantom sensation and phantom pain intermittently throughout the day. So after our mapping process that we explained earlier, we were able to find 3 referred sensation areas on this individual, on her anterior thigh and lateral thigh on her affected side. So using a soft bristle water paintbrush, we were able to find the phantom heel, forefoot, and medial arch. Interestingly, when we switched to a stiff brush, we weren't able to elicit the same phantom sensations as we did with a softer brush. In case number 2, we have patient C, a 50-year-old male who underwent a transtibial amputation in 2020 due to an MVC as well. He states that he frequently experiences phantom sensation, however, does not experience phantom pain. After the mapping process of both his upper and lower limb, we were able to find 1 referred sensation area over his patella, and this correlated to his anterior shin, just distal to his amputation level. Interestingly, we were able to elicit this sensation with a stiff bristle brush, but not so much with a softer brush as we did in the first patient. And then in our third case study, patient W, a 52-year-old female who again received her amputation surgery in 2020 due to a motor vehicle collision. She experiences phantom sensation and phantom pain quite frequently throughout the day, and she grades her phantom pain to be between a 3 to 7 when it does occur on the pain scale. And when we complete our mapping process, we're able to find a few referred sensation areas on this individual. On the medial aspect of her limb, and this correlates to the top image, we were able to elicit sensations of the heel and the lateral foot. On the lateral aspect of her lower limb, we found referred sensation areas that correlated with her dorsum foot as well as her Achilles tendon. And then moving up to her upper limb, we're able to find 2 referred sensations areas on her forearm as well, her medial arch and her forefoot. So we found it quite interesting. Even within this group of three individuals, we found different types, different numbers, and different locations for these referred sensation areas. So while this area has been explored quite a bit already, we as a research team thinks that there's still a lot of questions and answers to be explored, hence our research proposal. So going back to the phantom stimulator, once we find the referred sensation areas, we're able to calibrate and install the phantom stimulator onto the individual's prosthesis. We can insert the force sensors underneath the prosthetic foot as well, and apply the transcutaneous electrodes over top these referred sensation areas we found. By doing so, we have effectively recreated a closed biofeedback loop. There has been some studies in Europe that have looked at this type of neuroprosthesis in the past, and it has shown that by recreating this closed biofeedback loop, we're able to effectively cause changes in an individual's gait parameters and gait speed, static and dynamic postural control. And this is especially true when navigating obstacles or uneven terrain, their balance confidence, embodiment, and functionality of a prosthetic user's prosthesis, as well as phantom limb pain and quality of life for these prosthetic users. So for our study, we hope to just focus mainly on phantom limb pain and quality of life. So our proposed project design is a prospective randomized crossover pilot study within patient control. Our main question is focused on feasibility, on whether a larger scale project is feasible. We're curious about this because a lot of the studies we have reviewed from Europe have been on a smaller scale, and we hope to be able to conduct a larger scale project. So our 4 feasibility objectives include recruitment rate, and this will be based on our inclusion-exclusion criteria, eligibility rate, based on the presence of referred sensation areas, adherence rate, if patients are wearing the phantom prosthesis with their prosthetic and if they're using it to its full potential, and finally, the treatment effect of phantom limb pain. Our secondary questions revolve around phantom stimulator and how it affects individuals' quality of life, socket comfort, and as well as some qualitative experiences and perceptions of this new technology and using the phantom stimulator and integrating it into their lives. So for our pilot study, we hope to recruit 16 individuals. Our inclusion criteria includes adults with unilateral non-vascular transtibial amputations. They have phantom pain of 3 or greater on the pain scale, and they have been using a prosthesis for greater than a year. Individuals would be excluded if their amputation was vascular, diabetic, or congenital related. Individuals are pregnant or currently in the process of receiving a new prosthesis, or the individual has a pacemaker, implanted pump, or any other endoprosthesis that may be deep to the referred sensation areas or electrodes. So in terms of the study timeline, participants can come to our study for up to 4 visits. At visit number 1, we'll look primarily for the referred sensation areas that we're interested in, that being the heel and forefoot. This will be done by using our mapping process that we explained earlier. So if we're not able to find any referred sensation areas, the study will unfortunately end here for that participant. If we do find the referred sensation areas of interest, we will ask the participant to return in 2 weeks' time. Here, we'll collect baseline measurements, as well as randomize them into group A or B. Both groups will have the phantom stimulator installed on their prosthesis. However, only Group A will only have their phantom stimulator turned on, and Group B will be the control. We'll collect immediate outcomes after the installation, as well as after a 2-week intervention period, where they'll be sent home with the phantom stimulator. After these outcomes are collected at visit 3, individuals will cross over to the opposing intervention group. So Group A will now become a control and have their phantom stimulator turned off, and Group B will have their phantom stimulator turned on. Again, immediate outcomes will be collected after the crossover, and again after a 2-week intervention period when they use the phantom stimulator at home. So that will be collected at visit 4, and this is when we'll conclude the study and recollect the phantom stimulator from the participants. Individuals will also be provided with a patient diary where they can log the amount of hours they were in the prosthesis and phantom stimulator, as well as any concerns with using the technology or the general experience that they have with using the phantom stimulator. So where are we now for our study? So we currently have provisional acceptance through our ethics board. We're just waiting on some clearance through Health Canada to proceed with our study, because this is a device that has not been used within Canada yet. And just with the delays with COVID-19, we're just waiting a little bit longer than we hope. But hopefully we can get started with our project soon and be able to share the results with everyone once we have that. So I'd just like to give a big thank you to the rest of my research team, Dr. Grad, Dr. Fleet, Karen Littman, Dr. Packham, and Dr. Tavani for all their work and support on this project. As well, I want to thank the company as well for helping us get connected with the technology. And thank you for listening to our talk today. So if you have any questions, Allison and I would be more than happy to answer them. And it would be interesting if anyone else has had any experiences with referred sensation areas as well, if you'd like to share them.
Great. Thank you so much for this interesting talk and study that you're going to be doing. There's a few questions in the chat. Jeanette is asking, how long does the mapping process take?
So talking with our colleagues in Europe, they would typically book half a day to complete the mapping process. That's because you want to integrate as many breaks as possible into the whole process. And I think that half day also includes calibrating the phantom stimulator for the individual as well. And everyone's different, so it's they would prefer just allotting that half day to ensure that there's enough time. When we did our case study, we conducted it in, it was a very short period of time, I would say. I spent half an hour with the participants doing that mapping for our case studies.
And then next question from Jacqueline, how many participants did you map? Was it 3 out of 3 that had sensations, or was this a subset of more cases tested?
We actually only had time to do the 3 participants, and surprisingly, all 3 of them had the referred sensation areas. I think as a research group, we were a little bit surprised with that results, because we haven't had heard anyone feel referred sensations by just brushing on their skin in the past. To hear that we're able to elicit phantom sensations in 3 individuals is quite interesting to us.
Great. And do you think improving phantom sensation, could affect the amputee motor control? So if their phantom sensation is better, do they have better control over their prosthesis, do you think?
I can take this question. So I think that That's one of the questions that we're hoping to answer, is that this type of stimulation will improve control over the prosthesis. Through the studies, they are smaller studies that have been done in Germany right now. They have shown that it improves the mobility just by getting that sensory feedback that feels like your phantom foot. That's part of the reason why in our study design now, we're doing immediate outcome measures as well as in 2 weeks. So what we've heard is that once you provide that stimulus to those referred sensation areas, it provides that stimulus that feels like your phantom foot. It immediately changes the way that you can walk, or immediately changes your ability. So that's one of the things that we're hoping to better answer in our study, but it has been shown in the studies that have been done in Europe that it does improve mobility.
And I think you guys already answered this, but you can correct me if I'm wrong. I don't think it's available in Canada now because you're waiting for Health Canada approval. But any idea on the cost of this system?
That's a good question. Unfortunately, we don't have any information of what the cost would be for this type of technology when it does come available in Canada.
And then Evan, so one of our processes, is asking, is there any evidence to show that higher pressure or socket forces would cause phantom sensation or pain?
That's a good question, Evan. That's one of the questions we have as well. And part of having different types of brushes, so stiffer and soft brushes, kind of help elude us to these types of questions. And we're looking at if there's other methods as well to elicit these phantom sensations, but we don't have that information yet.
We get to Jacqueline's question. So, and I'm unsure if you've looked into it, but have you found a difference from brushing to electrical stimulation? And she mentions that the perception can be quite different and requires different calibration. So have you guys been sort of experimenting with the two techniques?
So we haven't started with the electrical stimulation part of things. We did have the Cortex Sensorics company, so the people who developed this phantom stimulator, give us a demonstration of how to do the mapping, as well as what it feels like to have the electrocutaneous sensation provided through the RSA. So we don't have our own data right now about it. So what they've told us is that there will be a calibration process, a very fine-tuning process to make sure that that stimulus is not so bothersome that it elicits pain, but is enough to give that sensation that it feels like your foot is being touched. So there is going to be a process as well where we will be fine-tuning what type of stimulus, how much stimulus comes through the phantom stimulator, to make sure that it's a comfortable stimulus for the patient or participant, and not uncomfortable in that way. So it is different. We haven't explored that yet, but it will be part of our project when we're able to start it.
Last question before we wrap up. So Jeanette, thank you. She says, thank you for your presentation, which was great. And you know, we're probably all looking forward to hearing your results. Do you have any plans on sort of disseminating your results in the future? Maybe the next OAAC.
Yeah, hopefully. So depending, we're just waiting on this Health Canada approval. Unfortunately, it's been delayed, understandably, because of COVID, so we haven't been able to start. But as soon as we're able to collect data and have something more to share, we'll be presenting results next year. But I don't want to get our hopes too up, but that you'll hopefully hear from us next year.
Great. Well, thank you so much. And I think we're all encouraged by your work and sort of advancing prosthetics for individuals with limb loss. So we're heading into a break. The vendors are available to check out, and our keynote is going to start around 12:30. So thank you for everybody attending the session. And again, Allison and Patricia, thank you for all your work in preparing this presentation and great study. We're all looking forward to seeing the results.
Thanks everyone for joining us.